Good morning, everyone. Respected judges, I'm going to present my paper on offline artificial intelligence on smartphone for glaucoma screening at vision centers. I have no financial disclosures. And as we all know that the glaucoma blindness increases by 50% in the coming 10 years. And the previously undetected glaucoma levels, they are more in the underdeveloped countries. And in that also 50% have advanced disease and 20% are blind. So, and the number of ophthalmologists worldwide is 2 lakhs, but they are not sufficient to tackle the burden, and many of them do not do surgery also or have adequate surgical volume. So the need is to design technologies for the non-customers, and we have vision centers to take care of that. So a vision primary care center is primary care through vision centers. These are small satellite centers which provide synchronous telemedicine connection between the doctors and the patients. So using this fundus on phone, this is offline on the edge artificial intelligence integrated on a smartphone fundus camera. It generates a referral report in 10 seconds. It can be used anytime, any place, whether it is a remote eye camp where internet or electricity is not there. It can be used by anyone, by MLOPs, mid-level ophthalmic personnel, healthcare workers, general ophthalmologists, and optometrists. So AI generates meaningful information about glaucoma and not only just gives VCDR but also highlights areas of concern beyond VCDR. So the purpose of the study was to assess the performance of this novel automated screening tool for referable glaucoma in primary eye care centers in South India. It's a prospective cross-sectional study done between December 2021 to May 2022, and the mean age of the study population was 42 plus minus 13 years, and 48% were male. And our primary outcome was to check the diagnostic ability to detect glaucoma by the AI versus image grading by primary eye care or the vision center doctors through telemedicine. And the secondary outcome was diagnostic accuracy of AI and primary eye care graders compared against glaucoma experts for those patients who were referred to the base hospital. So this is a flowchart methodology showing that how we acquired the image. So when the patient comes in, we take a fundus, undilated fundus photo. We do the instrument does a quality check, whether it is a sufficient quality image or insufficient quality image. And if it is a sufficient quality image, we run the AI, and the AI gives the diagnosis whether it is it has to be referred because it is a glaucoma, or a referral required in less than 3 months, which is a dissuspect, and whether no referral is required. For those patients who required referral to the base hospital, they were referred to the base hospital. If the image quality was insufficient, the patient's pupils were dilated, and again this repeat image acquisition was taken place. And this, when the image was shown to the through the telemedicine to the vision center doctors, they were not knowing that this patient has been taken up for the study, and they, seeing at the image, they used to give their diagnosis that whether they feel it is a referable glaucoma or not referable glaucoma. So we had 313 patients. We excluded 14 patients because of other conditions or insufficient quality. And so we had 299 patients and 570 eyes in the study. And according to the primary eye care doctors, there were 82 patients who had referable glaucoma and 217 patients who had no referable glaucoma. But according to the AI, the true positives were 60. So the sensitivity, which came out to be as 73.2%, and the true negatives were 240. So our AI showed a higher specificity of 98.6%. So this is a table showing the same thing. And so the sensitivity to detect definite glaucoma, that is not referable glaucoma. Referable glaucoma had both glaucoma and dissuspect, but as this definite glaucoma, the sensitivity was 91%. This is when we compared the AI diagnosis of the referred patients with the expert diagnosis at the base hospital. The sensitivity was found to be 91.3, and the specificity, that is true negatives, was 91.6%. So the sensitivity to pick up glaucoma was high, with minimal over-referral of normal patients as dissuspects. As compared to PEC doctor, the primary healthcare doctor, which was who were mostly glaucoma fellows, they were over-diagnosing glaucoma, and the sensitivity fell down to 53.7% for definite glaucoma, and the specificity also fell down to 66.67%. So interpretation was sensitivity to pick up glaucoma was 50% with over-referral of normal patients as dissuspects. So maybe because of glaucoma fellows were feeling that whatever dissuspects also, they had to be referred to the base hospital. So we had a sensitivity of 73.17% and specificity of 98.6% for the AI, and against the specialist, the sensitivity was 91.3 and specificity was 91.67. So to conclude, AI detects definite glaucoma with higher sensitivity than vision center doctors, with minimal over-referral of glaucoma cases, and it can be a potential glaucoma screening solution. The AI has low false positives. Especially it is important in a low prevalent disease like glaucoma to avoid overburdening of an already stretched healthcare system. AI can be used as a clinician decision support tool, and it will avoid over referrals done by doctors who are juniors or vision center glaucoma fellows who are more in dilemma. So this can help in picking up true positives. Despite being challenged with fundus images alone, the performance was performing when compared against a specialist who had access to multimodal investigations, HFA, OCT, and everything. The limitations of our study was it is evaluated only in Indian population. Generalizability across the populations cannot be done, and performance based on severity of glaucoma has not been done, so it will be undertaken in future. Practical implications: Remedio fundus on phone with offline AI for glaucoma can be used for mass screening at remote places, schools, community halls, and workplaces. AI can help in reducing unnecessary referrals, and burden on glaucoma specialists will reduce, and they will be able to concentrate more on the real glaucoma cases who need expert advice and treatment. Thank you.
Thank you, Dr. Swati. That was a nice presentation. So basically, you said that the over-referral is less.
Yes, sir. Using the AI.
Yeah, but I just wanted to ask you, what is the prevalence of glaucoma in your cohort?
So same like Chennai glaucoma study.
No. In this database, how many of the patients over there actually had glaucoma, glaucomatous discs?
So of the patients who were referred to the base hospital?
Of the 590.
Yeah. So 82 eyes had either glaucoma or this suspect. So
So 82 out of 600 is about a 12% prevalence. Okay, so the thing is, your positive and negative predictive values are very dependent on disease prevalence.
Yes, sir.
So if you go to a prevalence value of 5%, which is what you expect in the community, your positive predictive value drops to about 60%.
Right, sir.
Okay, so that is the only reason, because the statement that you made that the referral is low because you had a relatively high prevalence of glaucoma and the suspects in your cohort. It doesn't detract from the fact that it is doing well. It's just that this is, once you go to the community, your predictive values are going to be poorer.